Good afternoon, y'all. Listen, it has been a morning. So I am going to pretend like I know how to use this fancy clicker and move quickly through the presentation today. Doulas, do it. How many of you know what a doula is? And thank you for having me. Okay, good. Most of you, it looks like at least half the room knows what a doula is, which is a unique thing, especially in a room of people who don't look like they're necessarily of childbearing age. So congratulations on knowing that. During our time today, we are going to talk about what a doula is. We're going to talk about the different models of maternity care, discuss the differences between midwives and doulas, the benefits of doulas, and explain how embracing Sankofa can improve maternal care, maternal health. So Sankofa is a Twi word from the Akan people of Ghana, West Africa. It means that we should go back and fetch it. It means that we should not be ashamed, afraid, or insecure about needing to go back and remember the things and information that we had to bring it forward in order to solve some of the issues that we're having today. So in the spirit of Sankofa, we're going to discover why doulas actually do it. Worldwide, infant and maternal health are used as measures of the health of a nation. This is across the world, and the United States is really, really unhealthy. Louisiana is at the bottom of the United States, so we too are very, very unhealthy. And it is clear that we must acknowledge that what we're doing and the way that we're taking care of mothers and babies is not enough and not well. So we're going to take a quick look at some of these numbers. Across the United States, about 3.7 million women give birth every year, and if there's any doubt that the birth rate in the country is going down, I've been updating my slides every year, and I'm like, I used to say 4 million. This is like the new statistics. It is really, really changing and going down, even here in Louisiana, as you'll see in a moment. We use the fewest amount of midwives when we're looking at first world nations. We have the most cesarean sections. We throw the most money at the problem. And in spite of all of that, in every marker for infant and maternal health, we continue to have the worst outcomes when you compare us to other first world nations. And we have ugly, ugly, embarrassing health disparities, particularly around infant and maternal health. This is the great state of Louisiana, where we all live and love to be, right? So in Louisiana, last in 2022, the statistics said we had 56,479 births. That's down where it used to be 60 and above. So again, we are declining across the country in terms of our birth rate. For preterm birth, babies born before 37 weeks of gestation, we rank 48th. For infant mortality, babies that die before reaching their first birthday, we rank 45th. And for maternal mortality, we're it. We have the worst maternal mortality rate in the nation. At one point, Dr. Gee would say that we are the scariest place to have a baby in the world, Louisiana, because the United States has the worst outcomes in the first world nations, and Louisiana has the worst outcomes in the nation, and so the scariest and most dangerous place to have a baby, especially for Black women, the state of Louisiana. 1/3 of our parishes are considered maternity care deserts, which means that there is not an obstetrician or a hospital or a certified nurse midwife available within the per capita that it should be for that area of that community, in those parishes especially. 13% of our babies are born prematurely. Across the nation, it's a 10% average. 11% are low birth weight. Again, compare that to the nation, it's 8.5. In 2021, our infant mortality rate was 7.2. That is 416 babies that died in the state of Louisiana before reaching their first birthday. And unfortunately, Black infants are 50% more likely to be born low birth weight and preterm, and they're twice as likely to die. Just a little to add in there, the preterm birth rate and the low birth weight, those are things that are indicators and directly connected to why there is such a disparity. So low birth weight babies and premature babies are more likely to be low birth weight, and low birth weight babies are definitely more likely to die. If we look across the regions, you guys are here in Region 2. You rank second. This was data from 2016 to 18, second with the highest infant mortality rate. Just thought I'd throw that in there since this is where we are. Our 2020 data, now one thing about maternal mortality data is sometimes difficult to really look at and to talk about because the numbers are old and it takes a long time for us to look at the data, and we have a perinatal a pregnancy-associated mortality review committee that reviews all of the cases. I used to sit on that committee. It became really emotional and difficult for me, so I'm no longer volunteering for that service, but I did it for some years. In 2020, the data showed us that 82 women died of pregnancy-associated death. This means that she was pregnant or had had her baby within the past year when she died. Of those deaths, 15 of them were actually pregnant-related. That means that the pregnancy itself caused or exacerbated the problem that created her death. So there's pregnancy-associated. I just happened to be pregnant and get into a deadly car wreck. And then there's pregnant-related. There's something about the pregnancy that made me so sick that I actually died. Now, the unfortunate part about it is regardless of the type of death, 80%, this is deemed by your perinatal maternal mortality review committee, deemed that 80% of those deaths were preventable. That is horrific. In the United States of America, and in our state of Louisiana, we should never have a death of a mother that is preventable, period. When we look at the disparity in maternal deaths, the graph on the left shows us all of the births, and you can see that Black women account for about 37% of the births in the state. But then when you look at the deaths, they account for over 60% of the deaths. Now, this slide with the graph was made from the 2011-2016 data, so it shows you that 68% of those deaths were Black women, whereas in that 2020 data, it's 62%. It's still over 60%. So we make up 30% of the births. I want y'all to understand what this means. We make up 30% of the births, but over 60% of the deaths. Problematic, Louisiana. Injustice and equality of all the forms, the injustice and equality in health is the most inhumane, per Dr. Martin Luther King Jr. So what about midwives? This is where the Sankofa comes in. This is where it gets good and exciting because we give you a problem, but then we're going to give you a solution. Think back. Who knows what midwives are? I think everybody in here should know what a midwife is. Even if you didn't know what it, no, few of you know what a midwife is and a doula. This is so interesting. Let's keep going. Okay, so there are two general maternity models of care. There's the medical model that basically says most people are high risk, everything is a problem, oh my God, don't let it happen, it's gonna happen here, we gotta prevent it, and everybody gets the same thing because we don't want anything to happen to anybody, but the reality is things keep happening, so it ain't working. The midwifery model of care says that people are individuals. It understands that birth and pregnancy are normal parts of our human lifespan. As women, this is what we do. We grow up. Everybody doesn't have to have a baby. Everybody doesn't get pregnant. But if you want to, you grow up, you get pregnant, you have a baby. It's a part of the normal life cycle. Care is individualized, and individual people's, not only their physical health, but also their social determinants of health, how they live, where they live, how their support systems are set up. All of this is taken into account in their pregnancy and birth experience. The Birthplace Lab looked at midwifery integration across the country, and they wanted to answer the question, when midwives are a part of the system, how well does it change outcomes, and how are those outcomes impacted by race? Now, the integration means you have a place to go. If you're at a hospital birth, you have an easy transfer into a hospital. Integration means that you can get reimbursed. Integration means that if you're in a hospital with a midwife and something happens and you get high risk, there's an easy way to get you to a higher level of care, that there isn't a lot of politics, that we all work together for the betterment of the individuals. And what they found is that when we have really good integration, we have better outcomes. That makes sense. Midwives in general do better, even with high-risk moms. Some of the benefits of midwifery care include things like reduced unnecessary cesarean sections, reduced interventions, lower rates of C-sections, low birth rate, preterm birth. All of these things can be improved when we have more midwives taking care of families. There is a long history and story of why we no longer have the midwives that we used to have. There was a time when midwives caught all the babies and doctors were only used when necessary. We need to Sankofa, okay? We need to look back, because there are many barriers to these benefits. Access to care, there are just not enough midwives, insurance, deductibles, stigma, and fear. Who are these midwives? We don't know who they are. Are they smart? Do they know what they're doing? We're not sure. Is it safe? Yes, it's safe and it's good and it's healthy. Educational barriers. Midwifery education can sometimes be very difficult. It's expensive, especially if you're not going to a university. There are no student loans, not even that we want them, but even if you want a student loan, for some of the midwifery programs, they do not exist. There's a real rigorous schedule. Preceptors in racism, and I put that up there because research also tells us that Black moms do better when they have Black midwives, but Black midwives are hard to come by, and one of the reasons is because the educational system is set up in a way that we have to ask white midwives to teach us how to be midwives, and sometimes the white midwives just honestly don't want to teach us how to be midwives, or they don't do it in a holistic, caring way that allows us to get the information that we need to serve our community. So it is a barrier to our education to becoming midwives. And then there are many state laws in Louisiana and across the country that impact who can become midwives and how midwives can practice, and that is also a barrier. Then we have the maternity care deserts, which I can tell you, if we allowed more midwives to practice across the state, a lot of those maternity care deserts, especially in our rural communities, would go away, okay? Because midwives want to be where the people are, and that's just a fact. You can ask them. Now, I guess you're now thinking, I thought this was about doulas, right? The woman on the left is a doula that I trained. She was up in Shreveport. She's now in Germany. She's left us because of the military, but she was a doula, and this is a picture of her supporting a mom. Dawn Collins, thank you for allowing me to use your picture. So I thought this was about doulas. Well, it kind of is, right? So what is a doula? A doula is somebody who is trained to support families during pregnancy, birth, and the postpartum period. Doulas are not midwives or not doulas. This is really important for us to put out into the community, right? Doulas support individuals with informational support, education, physical, spiritual support during the pregnancy and birth experience. How are they different from midwives? First of all, the training and the certification is very different. So with the certification and licensure, that doesn't hardly even exist right now. Right now today, there is no national or state regulation about who can be a doula. So any of you can walk out of here today technically, right? We don't want you to do that because there is a training involved, but you technically could walk out of here and say that you're a doula. So there aren't any barriers around certification and licensure. And then as it comes to education, our training is much shorter. So where I train doulas in 40 hours, it can take 4 to 6 years to train somebody to be a midwife. Doulas take a class like mine, and then they go forward and they're able to serve, whereas midwives have to go through a long process. They are clinical providers. Doulas are not clinical medical providers, okay? That said, they still do it. They do a lot. They do a lot of beautiful, beautiful work. And there are so many benefits to doula care, research benefits. This is not just things that we've made up. You can check the Cochrane reviews. These are research benefits. They lower the risk of C-sections. They shorten labor. They provide extra support for families, the partners. There is an overall increased satisfaction with pregnancy and the birth experience and the postpartum experience when a family has hired a doula. And when we move to community-based doulas, we see that the improvements are even more vast, right? So a community-based doula is someone who is from that community, looks like the community, cares about the community in a different kind of way. A community-based doula spends more time with the moms, and they're also going to decrease the risk of preterm birth, lowering our maternal infant mortality, and lowering costs, which I don't like to talk about costs when we talk about healthcare, because who cares how much it costs if we're giving good health? But I also understand that we're spending a lot of money and we're not getting good outcomes. So we might as well change something, lower costs, and have better outcomes. There are reduced barriers to having doulas. So the educational barriers are not really there. It's $700, $600, $500, even free to become a doula in a few hours. They are everywhere. We now have so many. I've trained over 300 doulas just myself in the state of Louisiana. We got doulas. You can go to blackdouladirectory.com and find a doula. That's a resource that I've put together in partnership with Baby Dove. So there are doulas now out in the streets. When I first started training doulas 10 years ago, we could not say that. It's a new day. We have doulas. Access is available. And there are not really many state or federal regulations. People can practice as doulas. Right? You can get yourself a doula. So there are reduced barriers with all of these benefits, and this is why we should have doulas. I also know that doulas are not the golden ticket. They are not the only answer. And so here in Louisiana, Sister Midwife created the Healthy Birth Ambassador Initiative, our Healthy Birth Louisiana Initiative, where we trained women to be community health workers, doulas, certified breastfeeding specialists, and childbirth educators so that they could support families across the entire continuum from preconception care into the newborn period, really providing a pillar of support in their communities, going into these areas where there are these maternity care deserts. Are they the golden ticket and the answer? No, they're just a part of it, but they can also be a nice big part of it. You all heard in my introduction that I like to say birth is the revolution. And if we revolt, that is to rise up against the status quo and shift the way we think about conception, pregnancy, birth, and the postpartum period, we can literally change the vibration of our communities. So we don't have a lot of time. That is it for me. Yeah, for questions. I did that on purpose. I was like, I'm gonna probably be late. That was not on purpose. But I'm gonna leave a little time for questions, dialogue, comments, if anybody would like to have.
Is there a model state that we could go to Louisiana could say, hey, we want to be more like X, or different programs?
I think right now, that is a really great question. Right now, everybody is trying to figure this thing out. So some people might point to California. I'm like, California is not Louisiana. You know, Oregon has reimbursement. Every state is really different and really tackling it based on their own populations and how they do. And I'm always like, because I've been a part of a lot of the legislative conversations and conversations with different people, and I'm like, not that I don't care what's happening in other states, we are so different. In fact, even in the history of midwifery, we were very different in that, unlike other states where, like across the South, right, where we are, pretty much all births a century ago were attended by Black rural midwives. Whether you were rich or poor, whether you were Black or white, you had a Black midwife. In Louisiana, that's not the case. We had Black midwives, we had Cajun midwives, we had Indian midwives, we had it all. From the South on the water all the way up to the top, we had different midwives depending on where we were from the community. We've always been different. We must attack this different. We party different, we eat different, we talk different. We gotta do it different, you understand? So I'm like, yes, look at the other models just a little bit. But what do we know? We know about ourselves. Part of the reason why I would say just go off the phone with Ochsner. They're trying to figure this thing out. And I'm like, we got to find out, what do the patients who go to Ochsner want? What do the doulas who go to Ochsner want? What do the doctors and the nurses who work at Ochsner want? Because we have the answers for ourselves. So the answer is no, but there are a lot of people doing different things that we can look at and see what they're doing. Nobody has done it well yet.
Who pays for it and who can use these services?
So anybody who is pregnant can use a doula. Right now, people mostly pay out of pocket. There are many grants and opportunities out there for doulas. So the Baby Dove Partnership, they do provide grants for doulas. There are nonprofit organizations. There's something happening at one of the hospitals here with the volunteers, St. Mary's, somebody or another, doing something at, maybe it's at Ochsner, I'm not sure, in Baton Rouge. I also know at Women's Hospital, they have a couple of doulas on staff. It's a pilot project that they're working on, and they work with some of the moms in the various clinics. But generally speaking, some insurances will take the HSA. The reimbursement conversation is happening. They're still trying to figure it all out. Generally speaking, a family will pay out of pocket, and what I say is cancel the gender reveal party, cancel the newborn photo shoots, cancel the big baby shower, have a little baby shower, but not the big baby shower with the $200 cake, and pay for a doula who's gonna cost you anywhere from $300 to $1,000, $1,200 bucks. Cash out of pocket. That is a barrier, for sure.
Of the percentages you shared, do you have a percentage of how many of those deaths are teens that are pregnant?
I do not, and I would have to say in all of my years sitting on the PAMR, I think I might have saw one teenage case come across that we looked at, so not to my memory, because we would have age and, you know, the demographics was all anonymous, but we still have demographics. And I don't remember, a couple of times, and I sat on for like 3 years. Thank you so very much. If anybody has any questions, thoughts, want to talk further, this is how you can reach me. I look forward to it, and thank you again for allowing me to come and share.